Okay, good morning everyone. Thank you for being here. It's like old times today, isn't it really? Going back a few years. Thank you to Giri for presenting the overview of the wider review. The other thing that you'll obviously be aware that we undertook in parallel with that review was a review of pre-exposure prophylaxis in the Welsh context, which, it's no spoiler alert to tell you, was introduced last July. But I'm going to start with how we got to that introduction, and then my colleague Rachel will present the clinic lessons so far from implementing it. So start with the definition of PrEP. I'm sure everyone in the room will know exactly what PrEP is, but here it is for you anyway. I won't read all of that slide out if you're unaware of what PrEP is. Essentially, it's a prevention tool, a new mechanism for preventing the transmission and contraction of HIV in high-risk populations. So when we started the review, we looked, and when I say the review in this context, I'm talking about the PrEP review, not the wider sexual health review. We looked at the last 6 reporting years for HIV in Wales to give us an average diagnosis of HIV in Wales. So over those 6 years, 2010 to 2015 at the time, there was approximately 153 new cases annually. It does go like a zigzag if you know the charts. I'm sure you all do. It's a bit like that every year. And we also looked at the estimated number of HIV-negative men-over-sex men, the highest risk population in this context, who attended sexual health clinics in Wales, and that numbered around 4,200. So the proportion attending who were diagnosed with an infection was just under 10%. So this is the cohort that we want PrEP to work for. This is a quick timeline of everything that we did and everything we produced. So let me just learn which one's the red dot button. There we go. So can you hear me still? We started it was about September we actually started the work, and then published at the end of November the evidence review, which is called Preparing for PrEP. I'm always available for a catchy title, if needs be. And that was submitted to Welsh Government. At the same time, the makers of Truvada, Gilead, submitted their request for, I can't think of the technical term now, to the All Wales Medicines group for a review of the medication. And so our review was one thing. There was also that going on simultaneously. The meeting of the All Wales Medicines group was in April 2017. They didn't recommend Truvada for PrEP in Wales based on things like costs and some concerns over adherence. Cabinet Secretary took that review and ours together and decided back in, I'm just skipping to the end there, in July 2017 to introduce PrEP into Wales on the caveat that we look at the issues around cost effectiveness and adherence over a 3-year period alongside other things. So in the interim, before that decision was made, we knew that there were lots of people accessing PrEP through private means, buying it online or from other sources. But the clinics, as you'll probably be aware, had no way of monitoring that other than anecdotally. So we produced, to help that in March, some management guidelines for the clinics to manage those clients that were accessing PrEP privately. So of course, as I've just given you the spoiler alert for, there was the All Wales Medicines report in April. Then Cabinet Secretary's announcement of the trial, and then we came up in June with our protocol for the 3-year study, what parameters will be collected, how it will be collected, what things we need to look for as part of this trial, and then in July, the operational guide for PrEP through the NHS, alongside those management guidelines. They're currently under review, and we'll be releasing an updated version of that in the near future. So the governance for overseeing PrEP in Wales is similar in many ways to the sexual health review's governance arrangement. We've also got an independent HIV expert group, which was brought together initially to do that first review that was published in November 2016. But now it exists to monitor the study as we go on over these next 3 years and beyond, potentially. That reports into a PrEP steering group into Welsh Government, which is chaired by the Chief Pharmaceutical Officer, Andrew Evans. So that's just to present the current findings and discuss the current issues with PrEP in Wales. And then that does report back into the wider Sexual Health Programme Board, which CMO himself chairs. So these are some of the practicalities about what's provided in Wales. So it's currently Truvada, the drug. If off-licence prescribing is required, that's down to clinical judgment based on the patient you've got in front of you on the day. It's based in the sexual health clinics that deliver HIV services in Wales. And the eligibility criteria is as follows at the moment. Again, we're reviewing this as we go through the 3 years now to just make sure it's appropriate, and we're also following existing practice elsewhere, such as Scotland and forthcoming BASH and BEVA guidelines when they come out. The parameters that we're looking at, so this has introduced 33 new clinic codes specifically about PrEP. These are trying to capture every important detail about people's experiences of being on PrEP. There's some examples of those 33 up there now. It's a lot of codes, but there's a lot we need to learn and a lot we need to keep an eye on as we go through this process. This is the data that was released, I think, January. Nod if I'm wrong, or shake your head if I'm wrong at the back. This was the initial data then from July up to January. So you see 429 accessed that were looking for PrEP, 378 were deemed eligible across the clinic settings. 74 of those declined, and the reasons they declined is at the bottom. You probably can't see that, but the biggest of the lot, just slightly, was people didn't perceive that they were at risk, which is an interesting finding in itself, because the clinicians did deem that they were at risk to offer them in the first place. They thought they met the eligibility criteria. Some were concerned about side effects. Some said they were using other protective methods, so the condom isn't dead. Some of us may think it is at times. And the others just didn't want it, even though it was offered. 261 of those 378 did start PrEP, and 43 at that stage were in the process of receiving it. The important thing of people who've started PrEP is none of those have contracted HIV. We expected there'd be some STIs because this is a high-risk cohort to be offered it in the first place. But I don't think that's as numerous as I was expecting, to be honest, at that stage. So of those 261 that had started PrEP, 182 were still currently taking it at December. 27 had just finished a prescription, hadn't just returned in time for this data. 8 had stopped taking it, and 44 were lost to follow-up. They were still possibly using it, not necessarily on a daily basis. Although 94% of all PrEP prescriptions were prescribed on a daily basis. This is preliminary data now up to the 8th of March, so you'll see the numbers have gone up quite significantly. 386 people were prescribed PrEP. When we did our initial review, we expected it to be around 560 in the first year. So this is now 9 months in. It's pretty much on track with what we predicted, to be honest. And again, you see the same kind of stats here. STIs have slightly increased, but of course, so have the number on PrEP. So I think the ratios are pretty proportionate. And this is preliminary data, like I say, but it will be out in the near future. The other important thing with introducing PrEP is to make sure that we're having an impact, not just in Wales, but we're working with those who are introducing PrEP across the UK, but also across the world, because it's new to everyone. So one thing we did was this article that was out last year from Hornenberg et al. In the journal AIDS. We provided the Welsh context to that, which is looking at PrEP introduction in Europe, similarities and differences. I've got the link for that if anyone can't read that, just let me know. We're also working across the 4 nations of the UK, and yes, including Northern Ireland, although they're not actually introducing PrEP at the moment. Scotland introduced it a week before we did through the NHS. England is just launching its impact trial of up to 10,000 patients. So of course we're going at it in different manners and some differences, but we're all trying to work together on consistent evaluation methods and the things that we're trying to collect. We've also worked with the European Centre for Disease Control to keep them up to date on progress in Wales and the UK as a whole. And myself and Zoe have also got a podcast coming out soon where we're talking about the PrEP experience as part of the Sexual Health Research Network's podcast series. If you don't know about that, that's run by Glasgow Caledonian University, and they look at a lot of sexual health issues, and they've done a different episode for each of the 4 nations on PrEP. And I think ours is coming very soon. So what's coming next? We've got a colleague, Dr. David Gillespie, who's here today, who's currently in the process of applying for a postdoctoral fellowship, interview in May, so good luck from all of us, Dave, for that. His proposal will look at the adherence issues and some of the attitudes towards PrEP, not just from those on PrEP, but those who are not on PrEP. The revised management guidelines that I talked about, we're going to bring those 2 separate documents into one. So there's for managing people who are buying PrEP online and also for managing those accessing through the NHS. And an outreach campaign is currently in development with Terence Higgins Trust and colleagues. It's inevitable I've forgot someone off this list, because I was trying to think of everyone that is here to thank. But there's been so many people involved, not just in the here and now, but in the development of the review of PrEP back in 2016. So many people, you'll know Vaughan Gethin's actively involved in this as well, his statement yesterday as well on Welsh Government. But I think a very special thanks at the back to Zoe Cousins, who, not just for PrEP, but in the Sexual Health Review in general, who I know has put in an incredible amount of hours in sexual health for Wales generally in the last year. So I'll hand over now to someone else who's been very instrumental in this and the review, Dr. Rachel Drayton. Thank you.
Thank you, Adam. Sorry, forgive me, I'm suffering a bit with my voice, so I'm hoping not to emulate Theresa May at her party speech, but do bear with me if I have to take a sip of water sometimes. So I know quite a few of you. I'm Rachel Drayton. I'm one of the consultants in sexual health in Cardiff, but I'm also chair of the Welsh branch of the British Association of Sexual Health and HIV at the moment, and as part of that, I've been sitting on the PrEP steering group and also on the Sexual Health Board. Where's the clicker here? So I thought I'd start off, hang on, if I can go that way, with a case, especially because we've all been listening to lots of facts and figures. So this is just a case to highlight really where we were before this all came out. So this was a young man who was 17 and presented in the clinic in 2004 after being sexually assaulted by another man. He was started on PrEP at the time, and he carried on engaging with the service, and it was quite clear he was quite a troubled young man, had lots of mental health issues, eating disorders, and was engaging in quite high-risk behaviour, was having quite a lot of unprotected sex with particularly older men. He became engaged with Barnardo's to try and help change his behaviour, and he continued to see us in clinic and had PrEP on multiple occasions over the subsequent years, as well as being diagnosed with several bacterial STIs. But unfortunately, 3 years later, in 2007, the inevitable happened, and his HIV test came back as positive. Excuse me. So this young man still engages in our service. He's still troubled by a lot of mental health issues, still engages in a lot of high-risk sexual activity, doesn't adhere very well to his medicine, doesn't engage very well with clinic, and that was really the situation that we were in up until very recently. And just to highlight that, so this is figures from the UK. So as Giri alluded to, it's quite difficult at the moment to get accurate figures about HIV diagnosis in Wales because of some of the shortfallings of the IT systems that we have, and I'm hoping that that will be something that will be looked into in future work. But this is really to demonstrate where we were. So from 2007 up until 2015, really we had very static levels of diagnosis in men who have sex with men, possibly just slightly increasing. So whatever health promotion and prevention programs were being put in place, we really weren't getting anywhere, and men were continuing to get diagnosed with HIV. So then sort of PrEP came on the horizon. Quite a long time people have been looking into PrEP and as a mechanism of prevention. But really the first really good study came out in 2004, which was IPREX, which was a multinational study, and actually showed a 44% reduction in HIV. And actually, a lot of this was in resource-poor environments where adherence was quite bad. And when people took the PrEP, it worked a lot better. But then on the back of that, we had two studies, IPEGAY in France and PROUD in England, which looked at high-risk MSM, high-risk men who have sex with men, and both of them showed an 86% reduction in on HIV, so really, really encouraging, with PROUD reporting as a number needed to treat of 13 to prevent an HIV infection. Now, these studies are in a very high-risk group and don't necessarily reflect the men that we're seeing in Wales, but it was felt that it was likely that people were going to start using PrEP, and as Adam mentioned, colleagues of mine started working towards developing guidelines for Wales. And then we were very pleased in April 2017 when the Minister made his announcement that we were going to get PrEP in Wales. However, it is a bit of be careful what you wish for, because it then became apparent we had a very short time scale to work out in clinics how we were going to manage this and how we were going to facilitate this. And so we were going to get the drug costs, the extra drug costs reimbursed, costs of additional testing, as well as HIV point of care testing reimbursed, but we weren't getting any extra resource with regards to staffing or other clinic infrastructure, so we were going to have to try and fit this into what we were currently doing. But we were very pleased to be getting HIV POCT, which several of the clinics have been trying to introduce for a while without much success, so on the back of this, it's an opportunity to introduce that. So if you humour me, this is the completely unpatented, unofficial Rachel Drayton remit of sexual health services. But this is really what I think our core remit in secondary sexual health service, specialist sexual health services is. So it's the management of complex conditions, HIV, syphilis, gonorrhea. It's testing and prevention in the high-risk groups and in the vulnerable groups, and the complex contraception. But an awful lot of what we do is the other as well. So is the managing the slightly simpler infections to manage, like chlamydia and warts, testing in other groups, and the more basic contraception. And I've introduced a little red line there, which is supposed to show where I think we are at the moment. So as Geary demonstrated when he presented the review, you know, we're not managing to see all these people at the moment. Certainly I know in Cardiff we're turning hundreds of people away a week who are mostly fitting into this lower risk group, but we're not able to see them. And obviously, this next slide. Oh, we're on the wrong way, sorry. There we are. So obviously with PrEP, it's going to be expanding this middle group of really what we think we should be doing, not just with providing PrEP, but it's going to be encouraging these higher risk men who have sex with men to come for 3 monthly testing, which is what they should be doing, but we know that they haven't been, but this is a driver to facilitate that. But it's really going to expand what we do, and there needs to be acknowledgement. It's going to mean that there's going to be less of the specialist stuff that we're going to be able to do in clinic. And I think that's why we welcome the review of sexual health services, and looking forward to hearing about ways that possibly might transform the sexual health, the way that sexual health is delivered for these other groups that don't necessarily need higher specialist sexual health services. Sorry, forgive me. I'll just get a drink. So we had to think in Cardiff about how we were going to run it, and we thought really we're going to have to set up a specialist PrEP clinic. We're not going to be able to deal with this in the general hustle bustle of the walk-in, and my understanding is pretty much all the other services in Wales felt the same really. They had to set up a specialist PrEP clinic. So in Cardiff we identified a doctor and a band 7 nurse to do 2 clinics a week. We had to take them obviously out of the general walk-in, so that decreased the amount we could see in the general walk-in clinic, but we earmarked them and earmarked 2 new clinics that we were going to provide it is. And the way that it works is that people are identified when they come in through the general clinic. Either they present asking for PrEP, or we identify them through taking their sexual history as a candidate. They have all their basic needs met, so they have their testing, vaccines, treatments, and then they're referred, appointment was made into the PrEP clinic. where they were seen by, as I say, either a doctor or a Band 7 nurse who would talk to them a bit more about PrEP, start them on PrEP. Then they would have a 1-month review, and then following that a 3-month review, as recommended by the Wales guidelines. And then in the interim, if they had any other problems, they would come just to the general clinic or the specific clinic we have now in Cardiff for men who have sex with men. Now, this worked fine for a couple of months, but then it became apparent that we had no space to book follow-up appointments into because they were all getting full of new patients. So we've had to change things slightly and set up a waiting list. So we now have, if we identify patients, they're now put onto a waiting list. And then when the appointments come up, they go to the initial PrEP clinic. And to try and free up clinic appointments, we've actually dropped the routine 1-month follow-up if the clinician deems it safe to do so. So we just see them at 3 months, and that's freed up some clinic appointments as well. Our waiting list at the moment is about 8 weeks. We've got about 30 patients on it, but we're hoping as we drop the 1-month follow-up, we'll be able to decrease that or at least prevent it getting much bigger. So the challenges we've met, so I did survey all the clinicians. I did an online survey from all the clinicians across Wales who've been involved with PrEP to get a feel for really what they felt the challenges were. And really the biggest non-logistical challenge that was highlighted is about eligibility in men who have sex with men. So it's quite clear actually on the coalface that there are really 2 groups of men. There are the very high-risk men who are having lots and lots of unprotected sex, who are going to the saunas, who are having group sex, who are not using condoms at all, who are getting bacterial STIs. And then there's the men who occasionally have a slip-up. So, for example, 2 men I saw recently in a clinic. One came in, symptoms of gonorrhea, having 5 partners in the last month, using condoms only about 25% of the time, going to the saunas. And then following that, a 40-year-old professional who travels with his work. He does sometimes have sex when he's abroad, but he always uses a condom. But occasionally, when he's back in the UK, if he goes out and he's had a few drinks, then he has a slip. And so he's had a couple of episodes of unprotected sex in the last 3 months. So there's quite a wide differential. So it's about assessing the eligibility, but also in some of these men who actually do seem to be using condoms nearly all of the time for anal sex, but say, I want PrEP just in case. It's very difficult to decline it. I had a colleague who said, you kind of feel like you're punishing them for good behavior by not offering it to them. And I think we're all aware as well in clinics that there are some men who know what the eligibility criteria is and who know what to say. And even though they are using condoms consistently, they come in and they say that they're not because they know that that's how they can access PrEP. So I mentioned about the gradient of risk and really what seems like the 2 groups. And I know there is a lot of work going on going forward looking at those and trying to tease those out. But certainly we've now changed our waiting list to having 2 criteria. So we now have an urgent and a routine criteria so we can get those men who really need it started on it straight away. So we base that on the number of partners and how many condoms they're using, whether they're engaging in chemsex, group sex, or sex on site venues, engaging in sex work, or if they've had a recent bacterial STI. Sorry, I keep going the wrong way. The other big unexpected challenge was about renal concerns. So in all of the trials really that have been published, there hasn't been very much mention to do with renal toxicity. So we know that tenofovir is associated with renal toxicity in people when we use it for the treatment of HIV. And it became clear that there's a group of men who can't start on it, or we won't start on it because either they've got abnormal renal function or they've got lots of other comorbidities. So I've done a survey of all the clinics to look into this, and it looks like about 4% of patients aren't eligible. But a bigger time pressure is that some of these men need increased monitoring because they've got renal problems. Their renal function is fine for them to start it, but we need to keep a closer eye on them, and that can sometimes mean monthly monitoring, which is obviously further pressure on appointments. The experience of this is really very interesting. It's quite variable. So across Wales, it's about 7%, but it's as high as 20% in one clinic, and that suggests to me that it's very different populations attending the different services. So, And then, so the last challenge, I would be remiss to my clinician colleagues not to mention coding. So Adam did allude to coding, and out of the 33 additional codes that we have to generate per visit, which is quite a few to think about, and out of the top 5 things that people said in the clinician survey they were worried about, coding was 3 of them. So you can see actually it's quite high in people's minds, both the time that it takes, but also the accuracy. And these codes are going to be responsible for giving us the information about the success of PrEP and the need for PrEP. But there's concerns about how difficult it is to code accurately when there's so many codes, but also the accuracy of what's being fed through to Public Health Wales. And again, Giri's alluded to the sort of inadequate IT systems that we have at the moment to try and feed that information through. And so we are working on systems to try and improve that and optimize our coding. But IT would really be a solution to that. So I'm nearly finished. So going forward, and the biggest concern I think we have in clinics is about sustainability. The numbers of men who are on PrEP are likely to increase. We don't know. None of the trials have really told us how long people are going to need to stay on it. So if people are going to stay on it and stay on it for years, then the numbers are just going to continue to increase exponentially. And we need to have a think about actually how we're going to manage to deal with that and what we're going to do with the other services that are displaced because we're dealing with that, and how we're going to measure that impact as well as the impact that it has on HIV prevalence and other STIs in the group who are taking it. But I think it's very good timing that this is coming along at the same time as the sexual health review, and that hopefully there will be ways to transform the way that sexual health is delivered to possibly the lower risk groups, so the sexual health services can focus on what really is the core of their purpose. Again, just to allude to the difficulties in data collection and the problems with the IT systems at the moment, but also about differentiating the levels of risk, both to make sure we prioritize the right patients, but also to make sure that that's teased out in the data that's being picked up. So actually we can look and say, okay, PrEP might not be cost effective if you use this eligibility criteria, but it is really effective in this group of men, and making sure that we can tease that out in the data that's collected. So I thought I'd finish on a case as well to be a bit more positive. So this is a case of, again, a young gay man was first presented to us in 2014 when he was 16, and disclosed that he was engaging in sex work. So he had been sexually abused in the past and was using sex work really as a form of self-harm, quite a troubled individual. Engaged well with us in service, started getting some counselling through our service about his behaviour, and had multiple STIs over the following years, and was on PrEP, PEP, twice in 2016, 3 or 4 times in 2016, so he was pretty much constantly taking antiretrovirals anyway. And he was one of the first patients we've started on PrEP. He's now HIV negative. He's continuing to engage with services and trying to turn his life around, but it really feels like we've given him a stopgap by being able to give him PrEP. So, you know, with all the hard work that this is causing us, it's definitely a really good thing, and it's wonderful that we trailblazing here in Wales. And just to show, so this is the graph I showed you before, but with the 2016 data, so I'm sure quite a few of you are aware of this. So in the UK, it does actually look like we're turning a corner with the amount of new diagnoses in men who have sex with men. There are probably lots of reasons to this, but a lot of this seems to be London-driven, and probably driven partly by PrEP, by the PrEP trials, and by knowledge that PrEP works and people are accessing it online. So it really does feel like we're turning a corner. And then last of all, I just wanted to say thank you really to all of the clinicians who are working in sexual health, who are providing PrEP, and for working so hard, and for also helping me by filling in the survey, and feeding back to me about renal complications.
Well, thank you to Rachel and Adam, to all our speakers this morning. So we've had a fascinating morning because we've ranged from the global landscape as it affects sexual health services, as Frank has outlined. What are the big thematic issues globally around inequalities, modernisation, demography, demand, technological advances, expectations of clients, the issues of discrimination, of sustainability. So we've had the global context. Then Giri's taken us through what's the state of play in Wales, and we've had that very rich presentation on all the different aspects of the review. And then Adam and Rachel have taken us through the real implications of a really key advance. And clearly, this has been really a major breakthrough, and we've sort of been talked through down to the individual client level. So we've ranged globally through nationally into individual practice. So we do now have 10 minutes in which you can ask any questions of both our presenters, Rachel and Adam, but also Frank and Giri would be happy to take any questions for them. Marie has a roving mic, so does anybody want to start the questioning? Marie, I'm afraid you're going to walk briskly across the room. Can you just say who you are? And if you've got a general question or whether it's to a particular member. Thank you.
Okay, I'm Sandra Williams. I'm a school nurse in Powys. And I just wondered, I wanted to ask Dr. Shankar, the number of abortions that were on the slide, does that include, or can we add to that, those that take place out of Wales but the residents are in Wales?
Sorry, thank you. No, I think the data that we have presented is the ones that happen in Wales. We haven't added the ones outside.
Because for Powys, obviously there's a lot of residents that would be accessing across the border.
Yes, yes, I do.
Hello, my name is Claire Lippitz. I'm Clinical Director of Sexual Health in Aneurin Bevan. A couple of questions about PrEP. When you said that the expected take-up number was 500, have you got any other predicted data on how many cases we're actually trying to prevent? Basic arithmetic is okay for me, but just looking at the 86% reduction from the EPA and the PROUD, that would be a massive reduction, but on the number needed to treat, that's a lot fewer, so I don't quite get the maths about that, but have we got a prediction on what we're aiming for? And the second question about condom use, are men who have sex with men wanting to use PrEP so they can stop using condoms to prevent their HIV risk, and they'll take the hit with other STIs? I wondered if there's any information about that from anyone.
I'll take them in reverse order, actually. With regard to condom use, I think the one thing we're missing at the moment is the qualitative data. We've got a lot on the quantitative that's fed in through the systems. We need to investigate a bit more people's attitudes, which I think is what we're going to look for in the next couple of years, certainly. So I think that will only come out in that, is when we have these qualitative interviews. Taking the first question, the 560 figure was taken, there was a survey done with Paul Flowers and colleagues in Scotland, which included Welsh residents. And we use that to quantify, based on the population of Wales, the potential number of high-risk individuals that could access PrEP. Whether that will go on, it's hard to say, frankly, but that was the figure we used at the outset, and I don't see that fluctuating wildly through the years going forward. I don't know if that answers exactly the question, but that's the best answer I can provide right now.
Whenever I need numerical data, I do ask public health people, but I don't know the difference. If you have an 86% reduction of, say, 140 HIV diagnoses for a year, then that takes you to a very small amount, so you're hitting 20 or 30 cases instead. But if you use a number needed to treat, then you're only taking out reducing by 30 cases and not by 120 cases. So that, to me, I don't get the arithmetic and what we're calculating, because that's really important when we're then looking at the economic evaluation of a 3-year programme.
Yeah, I mean, in this particular instance, it is very difficult to put a figure on the number needed to treat, because we are unsure of the unknown population at risk in the sense. So what we can do is then best estimate based on the survey results of what we think is the likely number of people at risk who will benefit from PrEP. But what actually will be the translation of effectiveness of use of PrEP in that particular high-risk population is what we will monitor in this 3-year period of the study. But the All Wales Medicines Strategy Group has already looked at the cost effectiveness of PrEP, and that was the initial recommendation made to Cabinet Secretary, that for the level of incidence that we have in in Wales at the patented price of the product Truvada, what was then, it would not be cost effective at that time. But still the decision to go ahead was made on the grounds of ethical reasons, that if there is an effective treatment available, it should be offered to the population. But we all are very well aware that the patent will come off soon, and then the pricing of the drug will come down, and which will be much more accessible. But still, what is the cutoff we draw a line for cost effectiveness is going to be difficult, because the incidence of HIV in our context is small. So it can't just be the conventional economic argument cannot be used, I don't think, in this. But anyway, the next 3 years will give us much more data. Rachel, do you want to add anything?
Yeah.
Okay, Claire. Yeah, I think that the 86% was the reduction from the group who took PrEP and the group who didn't. And the 1 in 13 was the number needed to treat in that population. Now, in Proud, it's a very high risk population. We're talking basically about mostly MSM accessing clinics in Soho. So obviously, it's not comparable. We don't know what the number needed to treat here is in Wales. My point is, I think that there are some very high-risk men that we do see. I think, as my cases demonstrate, and PrEP is really needed in these groups who occasionally I have a condom slip, or actually I use condoms all the time, but I might not in the next 3 months. I'm not sure if it is going to be cost-effective, but we need to be able to tease that out. Yeah.
We'll take one more question.
It's not a question, it's a comment following on about PrEP. My name's Olwen Williams, I'm president of BASH, and because I kind of look after sexual health for all of the UK at the moment, I have access to information from Public Health England. The commissioners in England have been told to start planning for commissioning PrEP in England, even though they're only 6 months into their trial. So it looks like, regardless of what the evidence, this is going to be, Wales has been cutting edge, along with Scotland, in introducing PrEP. From a qualitative point of view, one of the things that I'm finding in my own clinics is the impact it's having on the well-being of my slightly older men who have sex with men. Men who find it difficult to use condoms because of their physiology has letting them down, who are now actually finding that PrEP is giving them a second lease of life. They're using their condoms much more effectively, so they're adding to their general well-being, and they are actually actively commenting that. So I was going to sort of suggest that I link in, because I've actually been collecting that data in our interviews with follow-up patients. So I think it's not just about actually the saving or the preventive onward infection, it's actually on the psychological well-being of our patient groups as well that we need to look at this.
Thank you. Any of our panel members want to comment? No? Giri, do you have anything you want to? No? Okay, thank you very much. And on that very constructive and positive note, I'm going to bring our session to an end. We now have coffee, as you know, out in the reception area. Then you'll have the 3 parallel sessions to choose from between 12 and